Since the HITECH Act in 2009 to 2014, government spent 27 billion taxpayer dollars to get you, all of you physicians, and hospitals to use EHR, electronic health records. And the question is why? Why would they do that? You know, it's a lot of money, and I'm sure they had to take out tremendous mortgage loans on our existing debt just to do it. Why would they do that? So the stated goal that the government has is the holy grail of EHR interoperability. Jeremy, cue the singers. Ah. Okay. But, thanks, Jeremy. The real goal is the control of the practice of medicine to reduce costs, but it'll cost us misery and lives, and physician satisfaction, and potentially physician suicides, which we've already seen, which is probably one of the most disturbing things when the caregiver doesn't get care and exits, unfortunately, like Robin Williams, unfortunately. At any rate, there's lots of voices to adopt EHR. There's government, there's big data, there's IT, insurance, politicians, academics, which are Dr. Ammerling's close friends, physicians, nurses, lots of folks, and then like politicians in the middle. And basically, I don't know if you can read the quote here, but basically he says that you didn't think we were just going to give you the money, did you? You're going to jump through some hoops, folks, and then we're going to own you. So that's a bit of an issue. So on we go. I wanted you guys to meet the stakeholders because, you know, you usually think about doctors, patients, nurses, caregivers, things like that, family members when it comes to healthcare. You don't think about these folks. The hint on who are the stakeholders, it ain't patients and physicians. The so-called healthcare stakeholders, and I probably should have put that in quotations, our government is the biggest one of all in its own opinion. Insurance companies, of course, hospital health systems, big pharma, business special interests, and big data, HIT. So health information technology companies, internet companies, big business special efforts, insurance companies, lobbied the government with millions and millions of dollars, potentially more, to pass this act, to be able to bribe physicians and hospitals to take the bait. And they got us to take the bait because, you know, some of us bought the argument, this is going to improve care. This is going to make everything better. It's going to hurt for a while, but it's going to improve care. But does it, and has it, and is it worth the risk? So here it is, the EHR Trojan Horse. It was brought to the front of the halls of the medicine there, and it was brought inside. It was a big, impressive thing. It looked pretty good. It had lots to recommend it, but we'll have to see what happens when night falls, what comes out of it. And you can see potentially on the bottom there, our former President Ronald Reagan, the 9 most terrifying words in the English language are, "I'm from the government and I'm here to help." So this is pretty much the big money slide, the take-home slide. We'll review it briefly, and you may even see these things again. EHR controls your medical practice and finances, disconnecting the patient from the physician, violating patient privacy and their own HIPAA, which they seem to love, by sharing data with the so-called stakeholders and anyone else who may gain access to it appropriately or inappropriately. Patients are more reluctant to share vital personal data with an EHR recording. Clinical decision support as justification documentation will be used to control your practice, as Dr. Ammerling began that discussion. Forced electronic prescribing formularies. You know, we're all being penalized now if we're not electronically prescribing for Medicare patients. Is it worth the hit? Also, if somebody gets your information, they can electronically prescribe as you ad nauseum anywhere they want to, rather than someone who just steals a prescription or a pad and they're limited in what they can do. They can force pre-certification and prior authorization, which we all love, bureaucratic things, I'm sure, that don't really advance care. Forcing ICD-10 or any other arbitrary or unnecessary coding system on the entire industry. Billing and coding can be used by the stakeholders for denial of patient care and pay for performance, which we just discussed an excellent discussion between Dr. Greenwood and Dr. Ammerling on the risks and benefits of pay for performance. I personally see most of the risks. Billing and coding can be used for denials of patient care. Physicians and patients are made slaves of the stakeholders, and that's a huge issue, probably the biggest one of all. That includes the financial capture of medical practice, which we've pretty much seen. If they pay for it, you do it. They don't pay for it, you don't do it, and the patients don't want it. That's a problem. Regulatory capture of medicine through osteopathic continuous certification, maintenance of certification, and the ever unpopular maintenance of licensure, which uses those expensive certification artificial procedures, which haven't been statistically established to do anything to improve care, applied to your license. So any of you physicians who out there who are boarded and say, I'm grandfather and I'm really not going to worry, I'm just going to work XYZ. Well, there's pilots going on of maintenance of licensure. And if you don't do all of this artificial expensive stuff like the youngins just coming up, you won't enjoy a license to practice. And that is huge. All right, first thing you have to do is introduce some new languages. New language terms. The government changes and distorts the meaning of words. I mean, I'm sure you've read all the books, 1984, Brave New World, Atlas Shrugged. The first thing that has to be done is they have to change your English or your understanding of English. Bad is the new good, good is the new bad. You know, lots of things that don't even make sense. But if you hear it enough, eventually people take on with it. But you can see HIPAA is a big issue there, the Pretend Privacy Act, and lots of new jargon there at the bottom of the slide. And you can see on the left, your government at work, healthit.gov, where we were, where we are, and where we're going. And I guess the question is, where are we going, and why are we in a handbasket? So, again, this is more jargon, meaningful use. You'd think that patients and physicians, hospitals, things, would come up with words and concepts that would be useful to patient care. No, this stuff is not up from the bottom. Healthcare, in my opinion, is up from the bottom. It's from the patient to the nurse to the physician, all the way up to the highest heights. Unfortunately, the way it's being done these days is from the top down. And that's a problem, because the central planners always get it wrong, and they get it wrong at the expense of time, money, and lives. You can study this just so you can get meaningful use, stage 1, stage 2, and stage 3. People are trying to stagger through stage 2 now. But again, we have the specter of the issue with EHR interoperability. Thanks, Jeremy. I call it meaningless use because it wasn't developed to be meaningful at all. It was developed to say, if you want the money, you have to do what we tell you. Again, like the previous congressman said in my previous slide. There's many, many writings on the internet. This one was from It's Not About Meaningful Use by John Moore in the healthcare blog. You can see some likely scenarios which you may have seen in your practices: wholesale destruction, total collapse, utter emptiness, gross indecency, terminal isolation, sheer anarchy, absolute chaos. And these are all healthcare reform meets meaningful use. So back to some of the points. It disconnects the patient and the physician. You know, you can see the physician doing her job there, and you can see the patient. And the patient, of course, is sitting looking down at the floor. Her arms are crossed, her legs are crossed, and she looks like she doesn't want to communicate at all. The patient was probably sitting in that little corner there with a cup of coffee, trying to enter all of the data feverishly into the EHR so that she could get credit and get paid for the visit rather than see the patient. And the point was driven home recently in 2012 at the University of Florida. A study found depression may go overlooked when physicians use EHR. And that's certainly an issue. I mean, everybody out here, no matter what you're in, two very valuable things that you have are your eyes. Of course, you also have your ears, you have your hands, you have your head, you have your heart, you've got all your body systems. And if you're limited in those body systems, like we're using an EHR, you ever been to a doctor that uses an EHR? So tell me about your problem. Okay, that's very interesting. Tell me about your family history. It's terrible. It's just awful. The other option, I guess, is to do your patient care within the first 3 minutes and then jump outside for 2 minutes. So literally taking just about half of the visit just to do the documentation. So patients are very reluctant to share, as you could see on the previous slide. So my potential conflict of interest, I should mention, I hope medical economics doesn't think it's a conflict of interest, but I'm on the editorial board there since I was on the cover in summer of 2007 or 2008 for prevention. EHRs may make patients leery about sharing information. And both patients and physicians should have privacy concerns. They should be concerned about the lack of eye contact. They should be concerned that patients may withhold information. They may not tell you what they're thinking because you're taking it down like a court stenographer. They may give you less information or make up fabrications. Geez, I don't want to tell you if you're going to record all of that. So as a result, they may get poorer care. Garbage in, garbage out. Again, that's IT talk. Sorry to take from their industry. But how many of you people have had folks come in and saying, hey, doc, can I just tell you this? Yeah, let's step into an exam room. All right, start the recording. You know, it's kind of difficult. They'll also say, let me just ask you a question. And that's a lead into an office visit of at least 20 to 30 minutes. Let me just ask you a question. They tell the medical assistant, I've had cold symptoms for about a week. And then you walk in and they want to talk about STDs and erectile dysfunction. It's a big difference. It's a big difference. So having said all of that, EHR clinical decision support, again, Dr. Ammerling touched on this. The government's answer is to have the AMA, the ABMS, and the AOA develop evidence-based medicine. And we all know how reliable government evidence is, right? When it comes to the VA and the IRS and lots of other government programs. But you can see here, we've got the guidelines. Now, every medical decision going forward not only will be documented, but must be supported by algorithms and guidelines. So it's not enough that you and the patient agree on what to do, but the, quote, experts, close quote, have to decide that it's okay, and you may have to attach that to your note in the future to prevent malpractice. Well, doctor, who said you should add that medicine? Who's your authority for that? Where are the guidelines? And anyone can write guidelines. At 3 o'clock in the morning, I was writing guidelines, crazy things. And you can see big hospitals, big medicine, big insurance, big academia, and big government are all writing guidelines. And you almost want it to stop because the guidelines are being misused. I mean, they're helpful to have. It's nice to know what some group of experts thinks, but each patient is individual and different, and we can't treat them like a herd as we're supposed to with population medicine. We have to treat them Hippocratically one at a time. All right, ERX formularies. Of course, the insurance and government wants to control all of your prescriptions, and they can't do it with paper, really. They can make you buy more expensive paper, as they just did in New Jersey. By the way, the price has doubled because the government wanted to put a barcode on it. I'm not quite sure what that does, but it's not like a food product. I don't get the barcode. But at any rate, they want you to prescribe generics. And the patient could buy those, as I want to call him Dr. Atlas, but Dr. Umbear from Atlas MD pointed out. He can get, medicines nearly free. I mean, really inexpensive. And a local supermarket to us, they give diabetics free medicines with a prescription just to get them to walk in the store, because of course they'll buy food, probably all the inappropriate stuff, so you have to educate them about that. But at any event, they want you to prescribe generics, and you can buy them cheap anyway. And you notice on the left side, this is a popular EHR that's actually web-based. And the first screen that they give you when you say, okay, I want to prescribe metformin, they give you find prescription coverage. And you can actually go through and see what their prescription will cover. And on the right, there's another very complicated looking e-renewal coming from a pharmacy. So the other interesting thing that's been a phenomenon just in the past few weeks is the same prescribing and EHR on the left there. After all the credentialing, license number information they have about you as a physician, CDS, DEA, NPI, any other 3 letters you want to name, they demanded access to physicians' personal credit reports from Experian in order to verify who you are. Well, no offense. I'll tell you lots of things. You know, I'm used to be 5'11". I'm probably 5'9½". You know, I may be positive. I mean, there's things that I will tell you about me, but there's some things I have to keep private. I mean, you know, the things I do at home are my business. The things that I do in my personal life are my business. My credit score is my business, quite frankly, and nobody should have access to that. But they were demanding it and threatened to cut off e-prescribing. So, of course, I wrote a nice letter to the vice president of operations who helped start the company. And so far, it hasn't happened yet that they've stopped the e-prescribing. But the threat was there. All he could say was, I could understand how frustrating that must be, but shh, I could understand. But do it anyway. That was the subtext. You know, I love subtext. You know, sometimes I just read the subtext. Pre-certification and prior authorization, gotta love administrative stuff, whether it's paperwork, whether it's meaningless phone calls and time for your staff. Does anybody here remember the time you could do a direct admission from your office? Hey, I have a patient here. Oh, one guy? Geez, I'm dating myself. Oh, it's lucky I'm a fun date. At any rate, when you see a patient and they're sick and they need to be admitted, they're not crashing, but you know they need to be in the hospital. They have pneumonia or something that can easily be treated as an inpatient. You write up the orders, you write up the H&P, you say, here, Mr. Patient, have somebody bring this with you over to the hospital, or you could send them even by an ambulance if you wanted to. And then the hospital would take care of it from there. But now their insurance companies won't pay unless the admissions are pre-certified. Now, I tried doing that once in 2005. Ooh. Once in 2005, I tried doing that. I had a staff member on the phone for an hour while the patient sat in my waiting room, sick. And we couldn't get through and couldn't have it done, and I said, you know what? I give up. Go to the emergency department, spend another $2,000 of somebody else's money, and be admitted. I'm sure the hospital will love that. Now, of course, the hospitals love that. It's in their best interest to use the ER for everything because the ER has facility fees. In fact, x-rays at outpatient centers you could probably get for $35 or $38, like a scoliosis series. Children's Hospital of Philadelphia charges $1,100 for the facility fee. $1,100. And they said their actual cost is about a third of that, like about $450. I thought that was disgusting and repulsive. But that's just what they do at hospitals. So you have to prior authorize all testing. You have to prior authorize hospitalization. And even medications. Generic Lipitor, atorvastatin. I never thought I would see the day I had to pre-cert a generic medication. An expensive brand for cancer or something? Yeah, maybe. $1,000 a month? Sure. But really? For like $50? No. There are many legal and ethical implications of managed care discussed by Dr. Richard Hall. Again, you have the reference at the bottom from, again, the University of Florida at Gainesville. He discusses the impact of major changes in the control of decision-making and managed care protocols. He talks about the restriction of resources and gatekeeping systems and the specific duties of the physician. That's where they get you. At the bottom is the take-home message. Managed care, the onus is inappropriately on the physician, not government, insurance, or patient, or any other party. ICD-10, conversion enforcement. Anybody planning not to do it? Not if you're using EHR. You're not going to have a choice. It's going to be mandated down your throat. And it's another expensive government emperor with no clothes. And Betsy Nicoletti, who's actually of the coding ilk, published on Kevin MD, the ICD-10 Emperor Has No Clothes. The current system that we use has about 5,000 codes, which sometimes strains a little bit. The one that the world uses of ICD-10 has about 16,000 codes. Our version that they want to force down our throats, developed by the CDC and who else but the American Hospital Association, has 68,000 codes. And the example is there are 12 codes for eye conjunctivitis. So, and what if you're wrong? Then they're not going to pay? It's a game that you can't possibly win and you don't even want to play. At any event, she says that it includes needless specificity, absurd adherence to taxonomy, unnecessary detail about injuries, and not enough information about chronic illnesses to justify its use. And she mentions the Star Trek series, the bureaucratic mind is the only constant in the universe. You know, so if you can think about that for a second, like Dr. Bones McCoy, you know, him like pounding the table or something, going, "Damn it, Jim, I'm a doctor, not a certified professional coder." Right? So having said all of that, she believes it will do little more than increase the bureaucratic sides of physicians' lives at the expense of them being doctors. And of course, there's claims denials. Oh, but now they'll all be automated. They'll come right back in your face. Here's your claims denials, ladies and gentlemen. We're not going to pay you for the care that you already rendered in good faith. I think that's called bad faith on behalf of the insurance company. I'll look that up. But the claim denials will be automated, faster, and more numerous. Also, insurance and government data audits. You ever have somebody come to your office and say, I'm from the insurance company. Can I just plug into your computer? How many of you would allow anybody on the planet to plug into your computer with viruses and potentials for theft and things like that? Anyone there? Good for you. I make them come and copy my paper charts, ladies and gentlemen. And when they come, I say, I hope you brought a battery backup because it's not my job to give you electricity. Sorry. You'll have to come back another time. And besides, I need the exam room to see patients anyway. I really don't have a space for you. Yeah, sorry about that. So you notice here in the right bottom, according to the CMS, everybody's friends, claim denial rates could skyrocket by 100 to 200% in the early stages of coding with ICD-10. I believe the early stages will be the first 5 years. And considering ICD-11 is almost ready, ICD-10 is almost arbitrary and ridiculous. But I think the government may consider, well, people have invested in it, so we should do that first, despite its ineffectiveness. EHR is a threat to patient safety. Who tells us that? Well, not our friends at healthcareIT.gov, but the health information industry of America actually lobbied Congress to get electronic records superimposed on all of our practices. And there was actually a study done, which I'm going to read from. They analyzed 100 consecutive patient safety reports from the VA, again published in Medical Economics. Of those 100 reports, 74 involved unsafe EHR technology, and 25 involved unsafe use of that technology. Well, that seems like just about all of them, doesn't it? Of course, the Office of the Inspector General doesn't believe that the government did a good job because it inspected itself and it said, hey, we didn't do a good job at certifying all those EHRs, that the companies that we anointed to do the surveying didn't do an adequate job to test and protect. And they say that these ATCBs, if you will, did not fully ensure that test procedures and standards could adequately secure and protect electronic health records. So they're being disbanded. But all of the EHRs that everybody out there uses in the community that were passed by these faulty guidelines and these companies that were inappropriately counseled are still in use today. So they remain dangerous to everybody. But we're not going to start again because we're government. Of course, your EHR data is always held hostage. Meet your new business partners. The power companies, you have an outage? I can't be a doctor, I'm sorry, I have an outage. I saw a patient by candlelight in 2001. You know, whatever it takes, you know what I mean? We're physicians, we're creative people, we're people that are driven to do things for patients. EHR tech company failures or issues, of course, computer equipment and peripheral failures, not to mention the cost and the time. And the doctor usually winds up the service department. You know, if somebody calls from the front desk and says, I can't log in, what can you do about this? Well, geez, I'm doing an exam right now. Well, which is more important? The government would say the data entry, of course. Your internet service provider could be down if you have a cloud-based program where your data might live somewhere else. So even if your company is working, if their ISP is not working and connecting to the internet, guess who gets nothing? You. You get nothing. The other problem is that data can be fouled, lost, or stolen by local employees and business associates. We have more and more of them. And the data can be fouled, lost, or stolen by hackers anywhere on the web. In fact, in Illinois, in 2012, a group with some real guts hacked a surgery practice. They encrypted all their records and demanded money to allow them access to it. Unbelievable. Can you imagine being hostage in your own office just because you're connected to the internet? Here's the bigger story, the EHR data breaches. I'm sure you all have heard of them. In the Washington Post, just 2 weeks ago, healthcare data breaches have hit 30 million patients and counting. In the last decade, records have been kept. 30 million. I challenge any of you to not know somebody that this has happened to. Perhaps it's even happened to you. I hope not. The government doesn't like that. Thank you. In Reuters, in 2014, Community Health, which owns several hospitals and facilities in many states, had a cyber attack from China, and 4.5 million records were violated, which included personal health information, which is HIPAA protected, so to speak, and social security numbers were stolen. 4.5 million in one foul swoop. Gone. Somebody will pay for this. And these are more business associates that you didn't even know you had. You notice at the top of the EHR pyramid, of course, is the government and HHS. And if you look down at the bottom, there is the new and improved, so to speak, health insurance marketplace, which, you know, failed miserably for the tune of, what, $2 billion initially with its rollout. And it connects you to all of the insurance companies, who I'm sure you're glad to know, who deny care. Also the pharmaceutical companies, whose pricing policies probably could use a bit of free marketness. At any rate, on the left side, you also see your EHR will be connected to AMA, who loves physicians. They love physicians so much, only 12% are members, just for everybody's edification. They also sell CPT codes, and that's how they make countless of millions. They sell these to the stakeholders in this picture. And of course, the AOA is here, as well as the ACGME and the American Board of Medical Specialties, because of osteopathic continuous certification, maintenance of certification, and the maintenance of licensure is going to be up here in the right, the Federation of State Medical Boards. They're going to want to maintain your licenses. And I know on the osteopathic side, which I have some experience, just to survey your EHR data every 8 years to see that you have improved care for your patients cost $3,000. And they said, you know what, this is just our cost on this thing. I find that hard to believe. Having said all of that. All right, survey of physicians. 70% of physicians say EHRs have not been worth it. 73% of largest practice would not purchase their current EHR again. And almost half of the respondents, 45%, say their care is worse since implementing an EHR. So this is your EHR reality. I'm sure you're well familiar with it. Again, EHR remote control. This is just a review. This is basically what EHR is, basically. It does everything for everyone instantly and makes you money. Except it doesn't grow hair like it says. I've tried it several times, and it just doesn't seem to do that. So I recommend joining AAPS and following at IP4PI for Independent Physicians for Patient Independence on the internet, and be super physician cutting through red tape. And there's more on EHR on the web, EHR Security and Privacy Mission Impossible, and EHR the Trojan Horse, if you guys want to Google it. And if you just want to Google medical economics and my name, Craig Wax, you'll see articles like EHR, Insurance and Government, when did we take our eyes off the patients? So thank you all for your attention. Now think and take action.